Hi, Dr. Ranjit.
Hello.
We can
Do
go
you,
ahead and start now.
you can hear me, yeah? Clearly?
Yes, yes, we can hear you.
Yeah, give you 2 more minutes and then we can start.
Okay.
Yeah. Hello, everyone. Good afternoon, good evening, good morning, depending on where you are in the world. First of all, thank you for attending this webinar. So, on behalf of Improve Academy, we would like to welcome you all for the first webinar in the series of simulation. So, basically, we are going to talk about implementing a simulation program in medical education and whether it will improve patient outcomes or not. So we're going to discuss the initial webinar series from today. We'll be starting. So today we are going to talk about what is the evidence for the simulation in medical education and where and how to start and implement a simulation program if you haven't started one in your institute. And then we want to talk about something called the open concept. Before I start, I would like to apologize on behalf of Dr. Alok Sharma, who is supposed to be doing the first two sessions today, but unfortunately, because of some family emergency, he is not able to attend today. So you have me for the whole next 2 hours for the simulation in medical education program. Okay, we'll start. So myself, I am Dr. Anjit Kumar Gunda. I'm I was trained in UK and did my neonatal CCT in from Southampton in UK. I'm currently working as a consultant neonatologist and also head of the Department of Neonatology at Ahlia Hospital Musafa in Abu Dhabi. So I'm also a co-founder for the Improve Academy. So if people haven't come across Improve Academy before, so we are a group of clinicians. Most of us are neonatologists and some pediatricians who come across to develop this multi-professional education to improve patient outcomes. So we target mainly improving our our programs mainly target about improving patient outcomes. What are the simulation scenarios and simulation strategies that we follow to that? So I'm also a course chairman for the Improve Simulation Instructor course. So the next course will be conducting in January in Abu Dhabi. So just to start from there, so as I said, conflict of interest, I'm the co-founder of the Improve Academy, and I'm also course chairman for this. So the whole purpose of this webinar is not to promote the course, is mainly to promote the simulation education. It's a heart and soul of all of our Improve team. And I should say I don't have any financial disclosures to make. So before, like, I don't know how many of you are actually uh, exposed to simulation, already involved in simulation. So for few of you, it might be quite basics to start with. If you're already in simulation, you would already know that in simulation, it's not like one-way teaching. It's like more interactive learning. And whenever I meet new people, I keep learning new things from them. So we just want to start some basics. What is simulation? Why it is important? And what is the evidence we have? So what is simulation? By definition, so basically a situation or environment created to allow an experience which almost realistic as possible. So the participant can practice, learn, and reflect themselves to improve their performance in the next time. Eventually, this simulation exercise wants to improve the patient outcome and the clinician confidence and team working behavior. So it is basically enacting the real play and recreate. So as a simulation facilitators, we need to recreate and imitate the real life scenarios for the participants to learn. So it is a methodology to replace or amplify real experience with guided experience from the facilitators that evoke or replicate substantial aspects of the real world in a fully interactive manner. So it's basically talking about it's an experience that need to be interactive. It's not a technology. It's not about technology. Simulation is not about mannequins. It's about a methodology of having a real-time experience and learning from each other's experience during the discussion of the scenarios. So why simulation? Lots of the first question most of the people ask. We all, as clinicians, we all practice. We all learned through our medical education, practicing on the patients and getting taught by our seniors in the medical school. So we have plenty of patients to practice. So question is, do we really need simulation? But the question is, yes, we need simulation because we don't want to practice on the real patient. We want to practice in a safe environment, which is safe for the clinician, safe for the patient. So, and particularly if you come across very unfamiliar situations, although whatever we read and learn through our training, you might be coming across some unfamiliar situations. The more you practice the unfamiliar, it becomes familiar to us and it helps us to manage more effectively in looking at the patient safety. So, so if you look at the like most of the amusement world, sports, entertainments. So if you look at the music instruments or sports, how do you get stay excellent in these in the professions? Because they practice individually, they practice as a group. Then only they can perform in the real life when the event happens. So if they can do it for amusement, entertainment, and other things, why can't we do it in the for the medical side? And it is much more important for us because in medicine it is highly variable work profile. We come across people, our colleagues who are trained very differently. Even example, I'm a neonatologist, so most of my examples I'm going to give you today will be from the neonatal side of things. So the neonatologist working in a neonatal unit, throughout your training, you're trained as a doctor, and currently, like once you come to the medical school, you are working as a junior registrar, where you're expected to work straight away with your nursing colleagues. Currently, the nursing education and medical education are separate. Working together again, that can be challenging for us initially. And we don't know, and we have juniors, seniors from various backgrounds, various countries, various institutes. We don't exactly know what their background is going to be. So the profession that we are in, it's very, very variable and it's very dynamic. It's keep changing. It's not like a sport or a music that we go particular pattern that we'll follow because our patients are very dynamic and very variable. So we need to be practicing more and more and more. And as we know, in front of our eyes, things can change rapidly until you have a good team effort and team working and the team ethics. It's very difficult to sometimes to save a patient. So it is important for us to practice even the very critical ones and also practice how to perform in the stress. These are the main important things why it is important in medicine to be very, very, very uh, practice or and do the simulation. So yeah, as I said, it's a multidisciplinary team effort. We are individuals who are trained differently. That we come across procedures, skills, counselings, difficult patients, so many other things that we have infrequent exposure to. So rare conditions which we probably might have read in the textbook, but we don't see it clinically. So these sort of things, when you planning a simulation scenarios, we look at two type of scenarios. Whether is high frequency, low risk events, which happen every day. So we all need to be 100% thorough with it, or it is like a low frequency, high risk events. It happens probably once in 6 months or once in 1 year. But as a team, we need to be very much efficient in managing those emergencies because it can happen. The things can change in minutes if you don't perform effectively. So, and also simulation is one thing that's as over the last 20 years, the more medical education is the simulation in the medical education has shown that by practicing simulation scenarios in your own institute, it will change your systems. You can identify the gaps in the system. so that actually when a scenario is conducted or simulation session is conducted in your institute, you identify where are the gaps in the real life, and it will help in the system changes. So we need to practice to one for individual uh, knowledge, skills, to test and improve the systems, to build the teamwork. And also we need to plan these things according to the target audience who we are going to teach to. Many industries already use simulation well before than medical education. Airline industry, military, or the most popular ones or common ones, they have been introducing long ago. So I should say like we are a bit late in the game, but definitely over the last 2 decades, the simulation in medical education has grown, and more evidence is coming out to say that it actually makes difference to the patient. It actually makes difference to the clinician's decision making. So initially it was only into the developed world. Now even the developing world is taking the simulation education as part of their curriculum. So why choose simulation? Simulation-based training is, as I said, it's an emerging innovation. It improves knowledge, it improves technical skills, it improves behavioral performance, it improves systems of care. In a way, we are targeting the people, targeting the teams, targeting the systems. So this is one type of education where if you have a design a program in such a way that all the team members, individual performances, team effort, and the systems can all be dealt with to provide safe, effective patient care. So what is the evidence? So although it's coming for the last two decades, the simulation education, directly extrapolating simulation education into improving patient counts, outcomes is still in the pipeline. Yes, there is a lot of evidence coming up, but main evidence that we see is improving the clinical skills most of them might have exposed. So if you practice on a mannequin, doing a cannula, doing a central line, doing endoscopy procedure, doing a laparoscopy procedure, your clinical skills improve, your knowledge is improving. Human factors, how you uh, interact with your team members during a emergency scenario. So there are lots of evidence that's coming out. It's already out that's improving the clinical skills, improving the knowledge and human factors. What is coming in the last over the last few years, 5 to 10 years, compared to the initial 10 years, was quality of care, patient safety. It has gone dramatically improvement, and very good thing was we can identify the system changes. Lots of system changes have been implemented. Altogether, it's actually improving the patient outcomes. So, what is the evidence we have? So, So for before going to the evidence, I just want to talk about this competency and confidence matrix. We come across different types of individuals. The top left corner, we have beginners who are generally not so competent and not so confident. They're beginners. They need some education and training so that they become competent and confident. In your team, if you come across all these four different types of people, the first one is the non-competent, not confident, who are the beginners or the junior residents who need a lot of hand holding and exposing them to the clinical knowledge, experiential knowledge, and guiding them through the career. Come across someone who is competent but not very confident. Simulation education is something that helps for these kind of participants very much, because these participants are not very confident because they feel stressed. They don't want to open up in front of the audience. When these people, these are competent doctors and clinicians and nurses, but once they are exposed to simulation education, what we have seen is their communication skills improve, their confidence levels improve, their knowledge skills improve. They become competent and confident. The third group is, I would say, in a medical world, is dangerous clinicians who are not competent, but they are very confident. They override the other juniors and clinicians who are more competent themselves. So, as a clinicians, as the senior doctors, it's our role to identify these individual people and put them into the simulation-based education training. So, all these three group of people will be benefited to become competent and confident. That is the target. It's not an easy task. Yes, it needs a regular exercise. It needs a lot of coordination and team briefing and debriefing skills. So the goal of our simulation should be getting a team of experts with the clinical knowledge, procedural skills, people who are confident, who will have good communication skill, and transforming them into a individuals with a team of experts, change to an expert team. They might not be expert individually, but the team they work very good. They're very expert in that. So our goal should be going to an expert team rather than individual expertise. So there is growing evidence that healthcare simulation contributes to increased quality of care and survival through skills training and team training that we have come across. The use of healthcare simulation does, however, reach beyond education. So it impacts patient safety, improving knowledge, attitudes in the healthcare professionals. And particularly in situ simulation, we can identify the system failures and implement the system failures in that. So we'll talk about the in situ simulation in the next talk. So what we already know in the last decade that there are a lot of evidence that's coming out, errors in teamwork equal technical errors as greatest risk to surgical patients. So it's not the medical knowledge, it's not the clinical knowledge that generally patient safety is compromised. In most of the cases, it is the technical errors or it is the team working errors that are human factors that has caused the main problem. So the lots of evidence I can show there. Simulation results in 20%. They are shown to decrease surgical morbidity and mortality by 20%, decrease the malpractices by 40%, increase the team principles, human factors in an emergency room in the operation theater by 86%. The good evidence to show 70% reduction in the bloodstream infections, 27% reduction in the time to team working and on the operation theater. So, and resuscitation time, safety threats, clinical skill improvements. I just keep going. I can keep go on for this evidence. But as you can see, there's all individual studies, small evidences that is coming out. In there are still very few randomized controlled trials that directly relates simulation education to the patient outcome. But all these individual studies have shown that in your own institute, in your own clinical area, it is actually making difference to the patient. I'll go through some examples. So medical team training program and surgical mortality. So this is a very structured program that has been done around the 74 facilities in training program. So what they have observed is by implementing both a protocolized approach and the simulation training, there is 18% reduction in annual mortality in the surgical patients, which is very, very big. Okay. And there's a decline in the risk adjustment surgical mortality by 50% greater than the training group. So just by introducing a simulation education program, we are able to reduce almost 1/5 of the mortality. That is a big change. So again, one of the common things that we all come across is bloodstream infections, infection control, catheter-related bloodstream infections. So it's a very good study that comes out on 2009, again back in 2009. Basically, it has shown there's 50% reduction in the bloodstream infections just by practicing simulation-based education program in the unit. So it's come from 3.2 per thousand catheter days to 0.5 per thousand catheter days. So it is a significant difference. So and technology is gone up and lots of research meta-analysis has been done how to see whether this actually simulation patient outcomes and also what about the education part of things. So technology enhanced simulation learning in health professionals education is associated with large effects of outcomes of knowledge, skills, behaviors, and patient related outcomes. So evidence is coming out to say that the knowledge, skills, and behaviors have significant improvement by simulation education, but still the effects on the patient outcome, the evidence is coming out. So this is a study done in the stroke center. Out of the 650 patients, including a 3-year baseline, intravenous thrombolysis, implementing a revised treatment protocol and simulation-based training, there's a significant reduction in door to needle time. That's from 27 minutes to 13 minutes, half the time. That improves the patient outcome. So again, evidence is meager, small numbers, But as you can see, more and more articles are coming out, more and more research is coming out. So again, this is another study showing the deteriorating response to the deteriorating patients, implementing a simulation program in a ward-based deterioration patients. It helps you in the, especially in the pediatric ICU, as help them to decrease the patient morbidity. So this is a meta-analysis on the surgical simulation and significant effect of simulation training on operative performance and also significant reduction in the operative time. So the more the clinicians and the surgeons practice by simulation education, the patient there's definitely improvements in the performance and also the patient surgical time. Still again, effect on this effect of the patient outcome is still coming out. So there's a very good study done in looking at the cesarean section, maternal and infant fetal outcomes by introducing a simulation education program across 2 hospitals in 2022. So what they have shown is that so the emergency cesarean section procedures can be significantly shortened by following a specific protocol and simulation education. And they have also shown that the neonatal Apgar score times at 1 minute improved by implementing the in situ simulation training program. So again, improving the mother outcomes and the baby outcomes together by doing a multidisciplinary simulation education. This is an example for that. So just summarizing the evidence together. So we've gone through the some definition of simulation, why simulation is important, what is the role, and what is the evidence that's coming out. I just want to pause it there if anyone wants to ask any questions.
No questions so far.
1 minute break and then we'll start again. Okay, so we'll start the second session. So we talked about. You can see my screen, yes?
Yes.
Yeah. So yeah, thank you so far to patiently listening in your time. So we talked about the evidence. We talked about why simulation is important. So if as a team, I hope I sort of convinced you that simulation is important to establish in your own centers if you haven't done so far. So next we're going to talk about how we are going to implement a simulation. How do we start doing it? So the two separate things that I want to talk to you today. One is how do I set up a simulation in the institute where you're working, and how do I start running a session? The two separate topics which I will be going talking through. So first thing is define your needs. Question is why you want to do the simulation program in your institute. It could be for the training for doctors and nurses. So as most of the countries have currently started curriculum mapping, like putting the skills as part of their curriculum for both the undergraduate and postgraduate medical nursing training. So it might be the part of the curriculum program that the institute might have to start. It could be because of the continuous professional development of nurses and doctors. It is for the quality improvement of the places where you're working and addressing specific departmental issues. I will address a couple of these things down the lecture. And it might become obligations from the hospital management, from the Department of Health where you're working, that you start simulation education. And it could be, yeah, for the name and fame, and someone wants some research to improve the patient outcomes. So, so the needs assessment is very important before you start thinking about why you want to set up a simulation program in your place. So because based on why you are starting the program, your implementation will differ and want to target so that you don't want to waste your resources, energy, time, and everything. So most of the things fall into one of these categories when you start. For me, when I first started, I should say it was the addressing the specific departmental issues when we started the thing, and slowly it went into the curriculum mapping and the quality improvement. Research is coming out. Still, we are doing some of this, but I'll talk about that in the next few slides. So if you look into the whole setting up a simulation, I can divide into 6 different categories: identifying a space where you're going to do it, identifying the equipment, the faculty who is going to do, how is it going to be funding, how frequently you want to do it, is it something sustainable, is it only one-off event. So we need to look into all these events, all these sections when we start thinking about implementing a simulation. First thing we talked about the space. So one of the main challenges that we face is uh, providing where we conduct the simulation. So there are 3 different ways of doing it. One is establishing a simulation suite. So very few institutes, especially the private small institutes, it might be difficult to have this facility. But most of the educational institutes, like the medical colleges and the universities, already have a simulation suite with them. So what's the advantages with the simulation suite? Simulation suite is a place. It's in a basically it's in a building. It's have a simulation lab separately. It comes with the technology. It comes with the separate lots of space for you. It has two-way mirrors, video technology. All these things are there. These are the advantages of it. But disadvantages: it is expensive. It is not realistic for the participants when they want to practice. So and also you have to buy and move a lot of equipment if you want to make it realistic. So if you run simulation through in a simulation shoot, if you're planning for a weekly work-based learning program, curriculum mapping, a structured nursing education and doctor's education, some things that you have to do on a regular basis for everything, simulation suit helps, especially for the procedural skills, especially for the technical skills. Okay, but something if you want to look into the human factors, it might not be the ideal place for you to look into. Next place where we can do is the what we call point of care simulation. This is basically, I'm giving an example. It's example, I'm a neonatologist, so most of my examples from my own experience. So this is the neonatal unit where I was working. So we set up a simulation in one of the bed space. So okay, so we have a ready-made, all our simulation equipment is ready. So whenever we want to run a simulation, we just block one bed space, making sure that it's not interrupting the patient care, and we run a simulation in that space. It's called point of care simulation in the place where you actually work. So obviously advantages is as close to reality as possible because you are inside the, for example, here you are inside the newborn neonatal intensive care unit where you actually deal every day. It might be labor or delivery room. So it's actually as close to reality as possible. It's an excellent way of doing simulation for evaluating systems and processes. So here where you can identify system failures and gaps in the system, and you can use the quality improvement for this. But the disadvantages of this are there. So it can be disruptive. You can't do it very regularly in this place. And if you want to bring outside participants, you can't do this. So you need a separate debriefing room where you have to take the participants away from the clinical area and go and have a discussion. And for example, if you want to put a high fidelity mannequins and high technology equipment into a clinical space, it can be quite disruptive to the other patient in the patient care. It can be disruptive to the patients and infection control. So you have to be very clear exactly what you are trying to achieve, what you want to achieve, whom you want to treat, whom do you want to train. So that if you want to train your own local trainees, along with addressing the system failures, for point of care simulation really works. But obviously, it can be you can't do it on a very regular basis because it can interrupt the patient care. So this it's a very good more way of doing identifying for the system failures. Next thing is what we call designing a sim suit. So in your own clinical area, there might be a place, might be an isolation room, might be an office, or which is quite nearer to your, like for example, my intensive care unit. This is the room where it's quite near to the doctor's room. We call this a neonatal sim suit. Basically, we duplicate the environment exactly like an ICU. The equipment what we use here, the monitors, the ventilators, incubator, the nursing charts, everything is duplicate of an ICU. It's like an alternative education area. It's not in the simulation lab which most of them sit in separate buildings. It's inside the clinical area, but not disrupting the patient care. Advantage of this, you can do regular practices here because it's already set up. You can, whenever you have free time in your thing, you can just ready to go areas. Obviously, disadvantages here, there are no techs available here, so you have to do all your work, and there's no two-way mirroring, and you again separate debriefing room can be a challenging here as well. So the three type of space identification where you're going to do your simulation depending on your target audience. And as we go back to the initial thing, that's needs assessment. So the needs assessment exactly tells you where you want to run your scenarios. It might be a combination of all three to address individual audience and problems. So you might want to do routine procedural skills in the simulation lab. You want to identify the simulation, the system failures in the point of care simulation, and you want to expose all your trainees and the nursing and the doctors not to take away from the clinical area for a very long time. You can just run a scenario for half an hour to 1 hour in this space, which is very adjacent to your NICU, where you can practice them for the real life emergencies. So all three of them has got their individual roles that we need to think about. Next thing is the equipment. So most of us, even me, before I start, when I say simulation, I think about mannequins. Yeah. So along with mannequins, lots of other things that comes into equipment includes the mannequins, it's a machinery, bed space preparation, the disposables that we use, the software that is involved, the virtual reality equipment that need to be used. So you will need computers, tablets, screens, projectors. So all these things need to be looked into when you plan for equipment. So one thing we need to differentiate and identify is difference between technology and fidelity. Technology basically means a mannequin or the equipment that have high tech and show a lot of technical advancement. But as we all need to remember, they're just piece of plastics and rubber. So sometimes the participants start interacting with the patient. They might not feel it's a real patient. So their learning experience might not be as effective. So what's the fidelity? Fidelity basically means you're creating the environment as close to the reality as possible. When it comes to fidelity, it's a combination of environment fidelity, equipment fidelity, and psychological fidelity. So when we say environment fidelity, when you're designing your equipment, designing your equipment for simulation program, environment. So for example, if it's a simulation lab we talked about, there you creating a neonatal intensive care environment is very difficult. So environment fidelity can be a compromise there. And but equipment fidelity, we have like lots of high tech equipment in the sim labs. So that might be useful for procedural skills, but you want to have a real time experience of a baby resuscitating in a labor room, point of care simulation or neonatal simulation suit, which is prepared in the unit itself might be more effective. So when you're trying to create the simulation program, think about all these three aspects of it. How to make the environment as realistic as possible, how to make the equipment as realistic as a patient, psychological fidelity. What it means, psychological fidelity means basically when the participant comes to learn, they should feel they're in the same role they're actually in their real life. They're interacting with the similar sort of people who interact in the real life experience. So if you're example giving them two doctors, one of them acting as a nurse, other one acting as a doctor, it might not provide the same fidelity in terms of real life experience because that other person is not a nurse. So if you want to develop the psychological fidelity as if they're doing in real life, your simulation program should have multidisciplinary. So your nurses, technicians, doctors, everyone should be involved so that they participate in their own roles to get maximum out of the the experience. So when you're designing the program, you should be taking all these things into consideration. And high technology doesn't mean high fidelity. They are very, very different. You can create a very high fidelity simulation session even with a very low technology mannequins, or other way around. Even with high technology equipment, you might not be able to achieve the very high fidelity simulation scenario. So taking all these three things into consideration is very important. So in the mannequins, we have high technology mannequins, medium technology mannequins, and low technology mannequins. To increase the fidelity, you modify the mannequins, you can do some moulage and use so modifications to it, you create the environment. So high technology mannequins, something like this, and I just want to again disclose a conflict of interest. I'm not promoting any particular brand here. I'm just showing some examples of the mannequins that we come across on a regular basis in our simulation education programs. So we have high technology mannequins. These mannequins, they breathe, they have heart sounds, and the baby cry, the baby blink, the baby can have a seizure, they can have arrhythmias. So they behave almost behave like a real baby. But if you don't do the environment fidelity as very effectively, the participant might feel it's just a plastic, and their learning experience might not be effective. So when buying the equipment, the high fidelity, high technology mannequins are very, very expensive. And sometimes you might have to go for a combination of low tech, high tech, medium tech mannequins, and use your fidelity measures to make it more effective learning experience for the candidates. As you can see in the right hand side picture, the baby, it's a very medium fidelity mannequin. The left one is a high fidelity mannequin. Medium fidelity mannequin, you put in a plastic bag, you have all this equipment that looks like a real life, covering the baby with a blood that's like a moulage. It provides a realistic experience for the participants when they're actually dealing with the scenario. Yeah, so these are examples of the high fidelity, the sim newbie, the gomad. High technology mannequins are there, premature babies, very high technology has come, but obviously, as I was saying, they're very, very expensive. Medium fidelity mannequins, so you can, they come some different shapes and sizes. As I said, examples are from the neonates. So these babies, like, we can intubate. They don't have any spontaneous movements. They don't have any spontaneous efforts. So as a facilitators who are going to run simulation, it's our responsibility to make sure the participant feels their high fidelity by using the medium tech mannequins. Low fidelity are like basically used for BLS, basic life support, and some basic clinical skills like bag and mask ventilation and CPRs. But again, as I said, even these mannequins can provide a real life good experience if you provide a good fidelity around it, including the environment fidelity and the psychological fidelity. So I'll give you some examples of mannequin modifications that we have done by using medium fidelity mannequins to converting into high fidelity mannequins. So this is a medium fidelity mannequin. Initially, it looks like that, where the mannequin doesn't have any special effects to it, doesn't have any spontaneous efforts. What we have modified the airway in such a way that it becomes a difficult airway, very anterior airway. So the participant cannot visualize the chords when they're actually trying to do the intubation. So the mannequin, which is quite simple, medium fidelity, medium technology mannequin, is become a high technology mannequin because of basic modifications that we can do in our mannequins to provide high fidelity. Same thing, we have blocked in a different scenario. We completely blocked the larynx with using a cotton and the bursting tape, as you can see. Here, by blocking that, we created a scenario how the participants um, react when they come across a baby where they can't intubate and they can't ventilate the baby. So to buy a mannequin like this, it can be quite expensive, but it's not very common. You don't have to teach everyone how can't ventilate, can't intubate scenario. Same time, you want have very seniors or your specialists, senior trainees where you want to even expose to these rare clinical situations. You have to think about modifying the mannequins, creating a micrognathia. So stitching the mouth like this to create like a micrognathic for the baby. So all small things that helps. So this is the gastroschisis model, a low fidelity mannequin. This is like a sausage casing. We put some jelly into it and coloring agent, and you make the it looks like a bowl, as you can see in the picture here. You can use for like green color to make like dark bowl, or red for a healthy bowl, or you can show some necrotic areas depending on how you want to run your scenario. This is the moulage. So by using paint and various things, we can create as if there is a injury on the hand just by using basic things like tissue, a color, and also some jelly. So these are things which doesn't need very high technology, but as simulation facilitators, we all need to learn how to do these things. What are the things that are available for us to do the moulage? And also as a low versus high fidelity. So the picture on the right side tells you again, this is a very medium fidelity mannequin, but once you see the baby, it's with providing the participants with all the environment fidelity as resuscitating a preterm baby, it looks like a real baby to you. So there are lots of other modifications that have been come across and people have been sharing across the groups. So ultrasound guided central line insertion models. So this is a chicken lungs and breast and people use that can be used as central line insertion models. And a coconut is used for ICP monitor catheter insertion model. This is a good example. I want to show the how you want to you want to teach your nursing staff how to give medication, whether you want to give it slow, fast, how are they going to run. You don't want to just ask them to just give it. This video helps you to show like we have created this. You have created this cannula and we have put the tubing and that goes behind the bed into a small jar. So during a scenario, actually the participants can actually give medications into the catheter. So it feels for them they are doing it for real. So again, all these small modifications will increase the fidelity of the scenario that will help them to have the maximum learning experience. So there's some different blood products that can be created using household materials and using small gloves and BP cup monitor using a peripheral arterial insertion models, ECMO cannulation models, exchange transfusion models, central line access. So this is just like an apron. There's not even a mannequin here. But when you want to teach aseptic non-touch technique for the nursing staff or the clinicians, this is simple model with very high fidelity that can actually help them to learn real life how to access a central line. The low-cost dolls, which, for example, if you want to deal with how to do suctioning and how to do care of umbilical catheter, you don't need a high technology mannequins. So using a low-cost dolls might also be helpful. We can get away with it. So think about all these things. It's a breastfeeding model using a shoebox, empty shoebox, and putting a T-shirt, shirt things, and smiley balls. All these things created like a breastfeeding model to teach the breastfeeding for the mothers. So obviously, these are all modifications and little things that you can add to increase the fidelity in your simulation scenario. Along with it, there are things like simulated monitors are available. So you don't have to move your clinical monitors into the simulated area. So you might have a laptop or a tablet that will help you. It's like a simulated monitor. So a few examples I'm giving someone is Simon, Simple, MedSim Studio. These are some examples you can download from the Android and Apple stores, where if you have two mobiles or techno or the tablet, like one can be used as a monitor, the other one you can use the facilitator can change the parameters based on the person's response interaction with the patient. So simulated monitors that I'll make it realistic. So this is like again example of how you created a environmental fidelity. Here it looks like a very sick baby on a ventilator with 5 infusions going on, and baby in a warmer here. But this mannequin is very medium or low fidelity mannequin. But as you can see the scenario when the clinician comes to run into this scenario, within short time they'll feel that they are in the real life scenario. They will forget that it is a plastic. They will start immersing in the simulation, what we say. So our role as a facilitators when we want to develop a simulation program, You have to learn how to increase the fidelity of the scenario. Same thing on the right side here. Very low technology mannequin, but with proper fidelity, environmental fidelity, with all the monitors, attachments, even the small things like how you place the baby in the real life. All these things makes difference. So high fidelity can be achieved with low technology equipment. That's what I want to show. So obviously everything has got a role. Everything has got a role. So we need to be clear what our audience are, whom we are going to train, what our resources are before we plan things. So, so first thing is to identify what you already have, like space. Where are you going to run the scenarios? What type of equipment you already have? What type of mannequins you have? Make a list of all the mannequins. You have a low fidelity, high technology, medium technology. Which ones you have? So getting them a list will help you to start running. So make an inventory of all the equipment that is available. So some equipment might be expired, which might not be used in the real life. It should not be in real life. That can be used for the simulation, but it should be clearly labeled. It's for simulation education only. So, and you can duplicate your resuscitation trolleys. For example, you want to duplicate an adrenaline. You don't have to have real adrenaline ampule opened every time you want to practice them. You can use a normal water for injection and label it adrenaline as exactly what your real ampule looks like. So all these small things that will help. So again, some more advances are coming into the. So I'm talking about a low, medium fidelity technology mannequins turning into high fidelity, but there are the technology advancing so much that it's come to the stage where the artificial intelligence and virtual reality is coming into the simulation. So I just want to show a small demo video. Again, I'm not promoting any brand here. I really like this video, so I just want to share.
Position to create new innovative products. We have created a breadth of technologies that we can now assemble as building blocks. The students nowadays, they come to the classroom with different expectations. They're expecting an interactive environment, something that's engaging. We're breaking ground with Lucina AR. For the first time in the history of training in medicine, the anatomy becomes visible to the whole classroom. Then you can see the progression of the baby inside the birthing canal. So that's pretty unique. Integrating HoloLens and holograms into a physical patient simulator. You can actually walk around the simulator and see the fetus, for example, inside the mother from different angles. Beyond the wow effect, there's a real educational value of having these holograms. The group is going to be understanding the same reality. So now the instructor can really focus on how to manage a complication. Nothing ever has provided that level of information. It's not a textbook, it's not a video, it's not a PowerPoint presentation that's going to give you that kind of understanding. CA Healthcare selected shoulder dystocia as the first scenario on Lucina AR because it's a rare complication of delivery, but it's one that's difficult to manage. You have a number of options, you need to think fast. Seeing the anatomy, seeing the progression of the baby in the birthing canal, and seeing where the shoulder gets stuck is going to be very helpful to understand how to fix it. Seeing them in front of your very eyes as a student is like a revelation, right? This is the future of healthcare education. Really beyond the spectacular of that experience, there's an educational purpose that we're fulfilling and that no other means or media has fulfilled up to now.
Training course. If you find the content useful in this format here on YouTube, we'd love to hear your feedback, and you can give us that either by hitting the like button or dropping us a comment below. By doing that, it'll help more
Hope you enjoyed the video. I really like this video, how the technology is advancing in terms of how the future generation is going to be trained. Um, I'll just start with this. So yeah, so knowing your equipment, knowing your resources, how much funding you have, you can create a simulation program based on what you need for your own institute and clinical areas. So next thing we're going to talk about is the faculty. See, although equipment and space can be expensive, but most difficult and very difficult is the faculty time. So getting you want your senior clinicians to get involved to learn and teach and simulation, which they might not have exposed as undergraduates and postgraduates. And for them, we don't want to miss their expertise in teaching the juniors. At the same time, you want them on board. Again, getting a faculty on board in a simulation program is going to be very, very challenging task. One of the main thing we need to identify is who is enthusiastic. So who someone you think can show some interest in simulation, please don't leave them. So can get hold of them so that you can start including them, whether the junior, senior, getting the human resources is very, very difficult. And multidisciplinary, make sure that your faculty is multidisciplinary because your programs most likely should be multidisciplinary so that everyone has got a learning objective from the simulation education program that you're going to do. At the same time, we need to make sure the faculty is trained. There's some certain training is there for them and certification for for the simulation education. And the most important time is how you're going to give them the time to come for the simulation education from their busy clinical schedule. So all those things need to be looked into when you plan for faculty. So it is important to have some institutes are very lucky that they have the dedicated simulation faculty who can do all this stuff. But if you're coming from a small setups or especially small private setups, if you want to establish a simulation program in your own institute, it can be quite challenging. So you need to identify people. You need to get your staff trained and get certified. The certification, the various certifications. One of the certifications that I'm currently in progress is CHSE from Boston. So all these certifications helps you to achieve the high quality simulation education educator faculty. So you make sure like all these things are taken into consideration when you planning your faculty. Next, coming in funding. So where is your funding coming from? Like the funding includes the equipment, the faculty and delegates time, the maintenance of the equipment, the travel, where you're going to move the equipment and how that the faculty is going to be moved. At the same time, you need to sell to your the management or the institutes what are you going to achieve by your simulation education program. One of the main thing that I have noticed over the last decade since I've been involved in this is a quality improvement. So maintaining the data, the what you're going to even the 1 or 2 sessions that you're going to do every month or so, please do maintain a schedule and the data and so that you show to your colleagues, you show to your management how your education program is helping them to improve the quality of care of the patient. So either you take small quality improvement projects, put simulation into it, or you take simulation education and show quality improvement to it. So where money doesn't match. So lucky to have QIs institutes. We have lot of money that can help you. There's some charity organizations which might be able to help, even the companies like Ladle, who in the some developing countries they're looking into maybe make the babies breathe. So they give mannequins and resources to run simulation education to the low resource countries, so to improve the patient care. And again, some if you want to do a proper research, grants are also might be able to achieve for the very good proposal. Think about all these things. Next, you need to think about frequency. How frequently you want to do it? Where do you? So we talked about where we want to do it, how are you going to do it, who is going to do it, and how you're going to get the money out of it for it. And then there's how frequently you need to do the simulation program to make sure it is sustainable. Okay, again, here I want to talk about the other thing I talked about the steps to design a curriculum. Again, initially we talked about needs assessment for a setting up a simulation program or setting up a simulation education program in your own unit. But here comes to designing a curriculum. So how frequently you want to do it depending on what you want to achieve, who you're going to train. So, so designing a curriculum based simulation education program is one way of showing how frequently you want to do it. For example, the place I was trained as a registrar in Southampton in UK, we have a simulation education program. Neonatal nursing and neonatal trainees have got a curriculum to be going through before they complete their training. So we put our simulation education into the curriculum so that all the trainees go through all these scenarios, all these particular curriculum areas to be comfortably placed before they become a consultant. So again, that needs assessment is important. You have to set learning objectives for each scenario, designing a scenario and debriefing patterns. So simulation steps, which I'm not going to talk very detailed today in the session. This will come in the next series, in next webinar, in the next 4 to 6 weeks. Basically, if you look at designing any simulation scenario, individual scenario, so you need to do the needs assessment, which means basically who your target audience is. You need to design a scenario based on them. And then you need to prepare a scenario for them, including the mannequins, equipment, fidelity, space, faculty, and running the scenario and debriefing. So these are the various steps that are involved in running a simulation scenario. So again, it's the same thing that you want to address the procedural skills, you want to address the emergency management, or you want to address the team briefing, you want to identify the system failures. So depending on what is your a learning objective from the individual scenario, you need to design the scenario accordingly. So I just want to talk about different types of learners you might want to come across, which will be slowly going to the adult learning principles. So we have learners who come from different zones, zone 0 to zone 4. So basically who are very novice beginning learners, some experience, senior expertise. So your target audience might be following into one of these zones. We need to identify. And at the same time, we need to see uh, sometimes you might have to have a multidisciplinary. So you have some zone 1 audience and some zone 3 and zone 4 audience. Because as I said before, the simulation education is not about the lecture and teaching. It's about interaction and debriefing and discussion that helps the juniors to learn from the seniors. And slowly, this as you move from zone 0 to zone 4, it changes from initially only the skills practice, procedures in skills training for the zone 0, zone 1 learners. From zone 2, 3, 4, actually we'll start seeing improving the patient safety, improving the quality of care, improving the patient outcomes. So depending on what is your target audience, what is your main objective of running the scenario, you need to identify your audience from across the zones so that you have a multidisciplinary scenario who actually have a good psychological fidelity. As I mentioned before, they should be working in their own roles. So you need to think about efforts to improve individual so that you have to give the performance feedback, the procedural skills, and also individual feedback. You need to think about team briefing, teamwork, human factors, and environment. So when you planning to address run a simulation scenario, your learning objectives, generally we say one technical objective for the individual person, individual the clinician. We have a team, the human factors, how the team perform, what can be, if any system failures that can be identified during the scenario that can improve the patient safety. So I'm going to give some examples that based on how we started implementing the program, how I got interested in simulation, and from clinician background into more coming into more simulation education background now. So as well, like I just want to summarize, we talked about the space where we are going to do it and what equipment we need. We talked about different types of funding that we need to achieve. who is going to teach it, how frequently, curriculum mapping and the quality improvement, and how to make it sustainable. Moving on to it, so a couple of examples. Our things started. So as I said initially, when we first started the simulation education program, it can be quite challenging to implement a program and take the program into your management to buy the mannequins and things for you. One of the things is to cascading the risk. So we identified this as a clinical problem. We identified there is a problem with hypothermia in the preterm infants. And the second problem we identified was increase in the umbilical venous catheter extravasation. Both these two conditions in the preterm and the neonatal age group are devastating and can have serious morbidity and mortality issues. So for us, hypothermia should be a never event. UVC should be as minimal. This extravasation can be as minimal as possible. So traditionally, before we started introducing the simulation education program, traditional teaching has been going on for years for all our trainees, including me. Once we started simulation education program, we significantly shown the improvement. This is the incidence of hypothermia for the babies born less than 30 weeks. So initially before like 2020, 2010, you're having 12 babies per year. Slowly it's come down to 2 babies. And like by 2015, we didn't have any baby with hypothermia admitting to the neonatal unit. So the traditional background knowledge continues along with the simulation education program has shown not a simulation education program just for the doctors. It's a multidisciplinary education program where we involve the doctors and nurses. Previously, the traditional teaching, nurses have a class separately, doctors have class separately. Here, the simulation education is a multidisciplinary education program. That's where the improve concept came for us. So basically, multidisciplinary education program that helped to achieve the improve patient safety and outcome. This is a real life experience for us. And since then, the hypothermia incidence in that unit is very, very less. Again, the UVC extravasation. So number of extravasations in 2013-12, as you can see. So 13, 14 extravasations, 7 extravasations, 6 extravasations, 2 extravasations. So as we started implementing the simulation education program, we were running roughly once a month for the UVC extravasation scenarios. We managed to decrease the incidence from 4% to 1%. So again, this is real life experience. I can't give you any better evidence than this. This is our own unit where we worked by implementing a simulation education program. We improved the patient outcomes for these patients. So as I said, as improve working together to improve neonatal care, it's improving the patient care by working together. That is what the simulation education is about. These are the examples of our in not point of care simulation, but you say in situ simulation, where we our own small seminar room in the near the NSU, we designed like NSU for like a NSU bed space, and we created a debriefing room. So that helped us to achieve this education program. One of the main challenge that we faced is we can't take your busy clinicians out of their working schedule for a long time. So whenever you feel there's a quiet time in between your schedule, you just grab 2 doctors, 2 nurses, take to this place which is not very far away from the clinical area, run a scenario for half an hour, 40 minutes, up to maximum 1 hour, and then they're back to their clinical area. So it doesn't disrupt the clinical patient care. At the same time, you'll be training them in the as realistic as possible near to the clinical area. Other thing that helps is the curriculum mapping. So initially, when we have to sell our simulation education program to our managers, one thing that helped us is addressing the risk for the 2 examples like hypothermia and extravasation. So the quality improvement. Next thing is the curriculum mapping. So we started showing that by simulation-based learning, we can achieve lots of curriculum areas for both the nursing, neonatal nurses, and neonatal medical training curriculum. So again, curriculum mapping helps you to make the program sustainable and get good funding and resources available for it. So Yeah. So we talked about the implementing the simulation program, how to brief introduction about how to think about the designing a scenario. But main thing, it's about your needs assessment. That is the main crucial part. So one of our role as from the improve group, we want to train more simulation instructors. So one of the things like we're going to do the simulation instructor course in January in Abu Dhabi. So yeah, so we have good expertise, Dr. Alok Sharma, Rajesh Sharma, and lots of other faculty who across the UAE that's going to help us to develop the education program. So that's the end of the second session. I would like to take a small pause if anyone wants to ask any questions. So if you don't have any particular questions, I would like to move to the third session in our webinar today. That is the open concept. So I should say that like probably the open concept is designed by the Improve group itself. So basically it's for the task training, simulation, and mainly useful for procedural skills training. So basically it's observation, perception, experiential learning. So I want to take some away from the practical aspects into some theoretical aspects. So as I said again, we're all adults. So learning, teaching adults is very different from the children. So it is mainly preparing the team and preparedness. So when you come to adult learning, everyone has got a different values, different attitudes, different skills, different knowledge base. So when you're running a scenario, when you're designing a program, when you're conducting a session, you should be thinking about your participants who come with the different backgrounds, including the attitudes, skills, knowledge, etc. So you're like if you look at the adult learning, how it runs. So most of them, when you start learning, your learning experience increases, and then your learning increases. Your learning curve is steep in the first few years of your career, and then sort of plateaus. So what you want to achieve by simulation is to take away this plateau and keep increasing the learning curve. So how do you do this? It is by you providing a exposure for these senior clinicians who might want to reflect on their practice to improve the quality of care, improve the patient safety, eventually improving the outcomes. So when you designing a scenario, you should be thinking about people who are can be could be where it could be in the bottom of this curve, or it could be in the like the top part of the curve. So we should be targeting your sessions and involve everyone in the scenario in the education program, so that your experience of individual candidates help them in developing their own reflection, increase and improve the practices. So the Miller's pyramid tells us about how we increase the professional authenticity as a clinician grows during their career. Initially, we all know a little bit of knowledge. We know we know how to do it. You might want to show in your exams and in terms of interviews how to do it. But main thing is doing it in the real life. That is the main challenge for us. So the simulation-based education becomes it changes from self-confidence to competent, increasing the operational performance and going up, increasing the effective care of the brain. So by simulation-based education program, you want to increase the confidence, competence, performance to provide the effective patient care. But we need to remember that your learners can be from different backgrounds. If you go through the COPE's learning cycle, so start from the right hand side. So there is so whenever we learn something new as adults, the first thing is what we have a reflective observation. We learn by watching. Okay. Once we learn by watching, then we slowly move into what we call, okay, we learn something, you want to make into a little concept of it, you start thinking about it. Okay. So first you start watching it and you start thinking about it. And then slowly you start doing the skill or doing the treatments. And then slowly, once you start doing the procedure, doing the activity, and then you perform the activity and you reflect on it and you change and you improve your skills. So all adult learners has to go through this learning cycle called COPE's learning cycle, which includes the watching, thinking, doing, and feeling. Okay, an observation and abstract conceptualization, active experimentation, and concrete experience. So all of us will have generally go through this cycle to develop our skills, knowledge, and patient experience and improving the patient outcome. But we need to remember when we start doing the simulation education program, your participants, some of them might be still at stage 1 or stage 2 or stage 3, and some of them must reach stage 4. So if you divide the candidates into 4 different categories, so the people who are starting from watching into thinking, they're still theorists. So basically, they're just learning the theory, they're learning the thinking about it, how to put things together. And then some people just stop there. They don't want to do it actually. They might be scared to do it. They don't have a opportunity to do it. So these are called theorists. So they have a knowledge base, but they haven't done in the real life or they haven't an opportunity to do it in the real life. Then we have the pragmatists. So now they have a knowledge. They want to put their knowledge into practice. They start doing into it. But initially they might be scared. They might not want to do in front of everyone. So some people stop there. People who actually take the next step and do, by doing an experiment, do a trial. I want to try an intubation for this baby with the help of a senior. These are the people who we call pragmatists. They think and do. And then people, once they start doing once or twice, they want to do it more. They're active people. So from theorists, you're changing into pragmatists, changing into activists. Once the participants reach the activist stage, then the concrete experience, because they're doing more and more of these skills and experiences, they start reflecting on it. Once they start reflecting on it, they'll identify some gaps in their own knowledge, in their own behavior, in the team, and they start looking into start learning new things again to improve the experience. So these are called reflectors. So watching, thinking, doing, and feeling, and you have different people's theorists, pragmatists, activists, and reflectors. So there might be people who have gone through all the 4 stages and be a reflector, people who are stuck at the level of theorists, people who are very junior to be theorists, people who are like gone through halfway through like pragmatists or activists. So when you're designing a simulation education program, you want to think about your multidisciplinary team. You might have all these different people at different stages of their learning exercise. Okay, this is where our open concept has come into practice. And also the another way of looking into it. For me, before I started this simulation education, I learned more by watching. Because once I start doing it, I feel scared, I feel stressed, I might feel that my learning experience is not so effective. I learn by watching and thinking rather than by doing. So you come across people who learn by watching and thinking rather than actually putting them to the stress and actually to do it. They might directly jump into feeling in the real life. So again, there might be people in your own clinical area whom you want to train, who might be just theorists, but they're also clinicians, so they have to do real life practice. So until all these people have a good learning exercise through your simulation education program, your education program becomes incomplete for you. So we targeting this, come up with concept called open concept, where we have an observational learning, a perceptual learning, and an experiential learning. So observation learning is for our theorists and reflectors. Yeah. So, and perceptual learning for your activists and reflectors, and experiential learning for activists and pragmatists. So when we design a program, we thought about, because take an example of that UVC extravasation scenario. Traditionally, the theory background has been going on for there's a traditional teaching going on in our unit. Once we started simulation education program, we started realizing some people learn more by watching and think rather than doing it and practicing it. But we want to expose them to the real life experience. So we're giving them an option for the experiential learning. So whenever you design a simulation education program, so you can't run every scenario like one scenario for 2 or 3 candidates. So generally, our way of doing simulation scenario is roughly around 6 to 8 participants in each session. 2 or 3 participants actually involved in the scenario who is actually treating the patient in the scenario. Remaining 3 or 4 are observers and involved in the discussion. The whole idea is, so all our 6 to 8 participants will fall into these categories. Some of them have learned by observation, some of them learn by perception, some of them learn by the experiential learning. But we make sure that all of them get a chance for the experiential learning. So to design this program with more effectively, what we have designed is for observational learners, for theorists, for UVC extravasation and hypothermia and accidental extubation, that another problem we had in our unit, is we created some videos, some theory classes for them on the same day. So it's a half-day program. The open concept runs like a half-day program for us rather than 1 hour simulation scenario. The open concept includes, instead they have a video to watch, they have a theory class to listen, and then they have procedural skills training on the same day, followed by putting all this knowledge together. They are involved in a simulation scenario. So they have an opportunity in a half day for observation, perception, and experiential learning. What we noticed by going through the open concept, the patient outcome is improved and more effective, and even the knowledge and skills have improved more. So we had a video. We make them deliberately practice the umbilical venous catheter insertion. We shown them the X-rays of the good position lines, abnormal position lines, and putting them to the simulation scenario with the increasing difficulty according to the seniority. And then we also went them through accidental extubation scenarios. So this is like a cycle they have to go through to improve the experiential learning in ICU. So as a part of that, the Improve Academy, we have done, it's a YouTube channel we have. We have lots of neonatal airway, central line series, lots of neonatal procedures that our trainees had an access to. And they can go through these videos whenever they feel they have to go back for some theory background knowledge. So before the simulation, one of the clinical problem we had in our unit was increasing incidence of accidental extubation. After our open concept, we started the video observation, deliberate practice, and X-rays, and then simulation experience. We come up with this decreasing almost no accidental extubations for few months in our unit because of the multidisciplinary education through the open concept for these ladies. So the advantages of open concept, the task training covers all learner types. The trainee might be performing a procedure weeks after the task training, so the videos can be reviewed at any time. So they have a chance to look at the videos whenever they want to. For example, they have learned UVC in session today, but they might not have an opportunity for a few months. So once they get a real time experience, they have a quick video that they can go through for like 2 to 3 minute videos that helps them to like an aid memoir to help them to remind them the basic steps of the procedural skills. And then again, the simulation experience that have gone through how to prevent accidental extubation, how to prevent the umbilical venous catheter extravasations, have helped them to actually change their practice. So again, as I said, we have looked at this example already. The UVC extravasation, the incidence has come down from 4 to 1.9%. So we designed the standardized videos addressing the multiple open concept that helps the multiple learner types. It has a multidisciplinary approach, and the advantage of this open concept is it's reproducible. The videos, the sessions can be used many times once you create them. So one thing we need to understand, one type of education model doesn't fit everyone. So we need to cater according to your target audience, your needs assessment, and setting up your objectives is the crucial before you start running the program. So I would like to stop there, and thank you very much for listening. I'm open to questions now. I think in this webinar today, we sort of covered the importance of simulation, how to implement it, the open concept of the simulation. In the webinars that are going to come in the next few months, we're going to talk about how to design a scenario, how to write up the simulation scenario, how to write up a learning objective, and then we talk something about the debriefing, which we haven't touched today. Thank you so much.
Thank you, Doctor. We don't have any questions so far.
Thank you very much. Then I think can we end the session there, Muhammad? You think?
For anyone who have a question, please type it in the Q&A tab. I think there's no question, Doctor. For the attendees tonight, we would like to thank everyone. We will send the evaluation link in the email. Thank you so much, Doctor. And have a
Thank you so much for everyone. Thank you.